Okay, good morning. We're going to go ahead and get started. This is Etta Rodriguez, and I'd like to introduce you to Florida Health Grand Rounds. We're excited to have Nakima Peterson presenting today. Just a few reminders before we get started. All phone lines are muted. If you would like to ask a question or leave a comment, simply type it into the question box on your GoToWebinar control panel. We will have time for questions and answers at the end. So go ahead and submit your questions throughout the entire presentation, and we will monitor it. Also, this presentation has been submitted for continuing education, but I have not received final word on whether or not it's approved. So go ahead and complete the survey at the end of the presentation if you're interested in those, and as soon as I get approval, I will create those continuing education certificates and send them out. If for whatever reason we don't get approval, I can still provide attendance certificates. And then here to do our introduction is Melissa Jordan.
Hey, thanks, Etta. Good morning, everyone. I wanted to start today by giving you a little bit of background on the Research Excellence Initiative, REI, that the Department of Health facilitates annually. REI is a year-long education program for Department of Health professionals with training on conducting research, epidemiology, and program evaluation. The program seeks to promote high quality and innovative research at the department, educate and recognize Department of Health researchers, develop experienced research capacity, and promote excellence by serving as role models and mentors, foster collaboration among department researchers, and promote research on department priorities like healthy weight, obesity, cancer, and other tobacco-related diseases, and health disparities and health equity. Applications for our next REI class, which will be Class 6, will be going out in early 2020. So hopefully look for that in January. The applications will probably be due at the end of February for a March kickoff. And so I also wanted to say that the presentation you will hear today is a project that Nakima completed as part of the REI and her participation in that. And so she's received a year of training and mentorship to help develop this through REI. And so this is a great, I think, example of the work that we're seeing and the mentorship and support for department research going on through REI. So a little bit about Nakima. She's the health data analyst for the newborn hearing screening program at the Florida Department of Health, and she has a background in epidemiology and biostatistics. Ms. Peterson is currently a pharmaceutical sciences PhD student studying health outcomes research and pharmacoeconomics. As a product of the Florida Agricultural and Mechanical University Institute of Public Health, Ms. Peterson's main research interest is maternal and child health. Ms. Peterson has had the pleasure of serving the newborn hearing screening program for a little over 2 years after completing her role as an intern epidemiologist with the Centers for Disease Control and Prevention. Ms. Peterson is committed to improving maternal and child health outcomes at the state and national levels through research that aids in evidence-based practice improvement. Please join me in welcoming Nakima Peterson.
Good morning, everyone here and on the line. Like Etta said, there will be a portion for questions at the end. So definitely, as she said, enter your questions as the presentation is going along. If you want to write down slide numbers, there will be slide numbers on the presentation, so I definitely encourage that. Thank you so much, Melissa, for the introduction. Again, I am Nakima Peterson. This research was conducted as a part of the Research Excellence Initiative, and also our program wanted to take time to critically analyze the data that we have available to us and see where we could improve our processes as well as improve the outcomes for the babies born here in the state of Florida. So this research has been presented at the national level at the National EHDI Conference earlier this year. And so I want to take the time to essentially use the research that was conducted as a tool in showing you all and everyone that's listening how you can use the data available to you and your resources to critically look at your program by, looking at the statistics, using your resources to see what areas you could be improving in for the population you serve. And so, yes, that's what the presentation will go over. Definitely let me know if you have questions at the end, and we will go ahead and get started. So Prevalence of hearing loss. Hearing loss is actually the most common birth defect. In the United States, about 1 to 3 babies out of 1,000 are born with a permanent hearing loss or impairment each year. In Florida, we average about 9,000 babies who don't pass their initial hearing screening. Out of that 9,000, approximately 300 babies are diagnosed with a permanent hearing loss or impairment yearly. So it's important to know the background statistics at the national level and definitely at the local and state level for whatever program area that you're interested in researching. It's important to know the background so you can definitely organize what you want to do with your research or what you want to do with your program as far as the analysis takes place. So what is EHDI? EHDI is the Early Hearing Detection and Intervention Program. It's a national program that was first authorized by Congress in the year 2000. The goal of the program is to enhance language, communication, cognitive, and social skill development in order for the newborn to be successful in school and other lifelong endeavors. So what the EHDI program includes is hearing screening, audiology, diagnostic evaluation, and early intervention. And a few examples of that are here. That initial testing is done usually wherever the child is born, so whether that be in the hospital or whatever birth facility. So a bit about our 136 goals. We'll get into the details of the actual data points a little later in the presentation. Since we know that hearing loss can affect a child's ability to develop speech, language, and social skills, the earlier the intervention is provided, the better chance the child has at reaching their full potential. So there's a body of research in this field that discusses outcomes for children with hearing loss or impairment, and earlier research essentially found that the earlier we can get the children identified as having a hearing loss or impairment, and the earlier we can get them into early intervention to help them with that birth defect, the better their outcomes are in the long term. And so the Joint Committee on Infant Hearing had a position statement or put out a position statement in 2007 that presented us with the 136 goals. And essentially it means that they recommend the child is screened for hearing loss or impairment by 1 month of age, that they are diagnosed, whether that be with a hearing loss or impairment or without, by 3 months of age, and that they're enrolled into an early intervention program by 6 months of age. Now, recently, just a couple months ago in October 2019, they put out a new position statement with a new set of guidelines, the 1, 2, 3 goals, and essentially those states that are already successful at pursuing and attaining the 136 goal, they recommend that you move towards 1, 2, 3. And the overall purpose of that new goal is just to increase the timing of when that child is identified as having a hearing loss and when they're enrolled into early intervention. So the earlier the intervention and identification, the better. So Florida EHDI. So the Early Hearing and Detection Intervention Program here in Florida is housed within the Newborn Hearing Screening Program within the Division of Children's Medical Services at the Department of Health. So our program attempts to obtain rescreening and diagnostic information on children birth to age 3 who did not pass their initial hearing screening. Our primary objective is to diagnose hearing loss early in the child's life in order to provide the opportunity for early intervention and positive outcomes. So this is a little bit about what our process looks like from birth to diagnosis. And again, it's really important to detail information like this because each area that I'll go through has been either in the past or in the present an area for improvement as far as the body of knowledge is concerned. And so from birth to diagnosis, of course, a child is born. And by statute, every child is required to have a hearing screening prior to hospital discharge. However, a parent can refuse. So the child is born, they have a hearing screening. They either pass that hearing screening or they do not. If they don't pass that initial screening, then they have a second screening because Florida is a 2-screen state. Not every state is a 2-screen state, but Florida is. So after they have that second screening, if they still, have not yet passed, then our staff here within the department, we do outreach and follow-up. And so essentially that is contacting primary care providers, audiologists if they've already seen them, as well as parents or caregivers to, inform those involved in this child's life and in their caregiving that they have not passed their hearing screening and they need follow-up testing. From there, a referral is made by the primary care provider or an audiologist, whoever conducted that hearing screen, for a diagnostic hearing evaluation. And this is just more strenuous testing to see whether or not that child has a hearing loss or impairment. After that evaluation, of course, a diagnosis of whether or not hearing loss or impairment is present takes place. And then we go on to our process of from diagnosis to early intervention. Now, this is a collaborative process. The whole process is very collaborative because we count on our hospitals and other birthing facilities to report to us information on whether or not the child has been tested and all of that information. And I can get into detail about that a little more later if you all have questions about that. So this is what our process looks like from diagnosis to early intervention. Once we receive a diagnosis of hearing loss or impairment, it is reported to us at the state level. The results are entered into our data system, or otherwise known as our EHDI information system. That baby's record is updated to reflect that permanent hearing loss or impairment. And then from there, our staff assembles essentially a packet of educational materials. They're hearing loss specific, and they go to the parent or caregiver just to inform them more about what it means for their child to have been diagnosed with a permanent hearing loss or impairment. From there, during this time, we also make a referral to the local Early Steps office by fax as well as through a secure email. Now, Early Steps, I say local Early Steps office. Early Steps is actually the state of Florida's Part C early intervention program. And so essentially, they're a separate program for the newborn hearing screening program, and they also have local offices throughout the state. And so what happens is we find out whatever local Early Steps office is closest to that child or that parent, that caregiver, we make a referral there, and then they take over the process from there. So that the child then moves into the follow-up process in early intervention for Early Steps. So objectives of the research that we conducted while in the RDI program and within our program, we wanted to examine our program outcomes in accordance with meeting JCIH recommendations, the 136 goals. We wanted to determine the distribution of our infant population in relation to the location of local Early Steps offices. And then we also wanted to assess areas of opportunity where the program would be able to aid in improving outcomes for our deaf or hard of hearing children or infants in the state of Florida. And deaf or hard of hearing is the technical term within our field for hearing loss or impairment. So this is the methodology that I used while conducting this research, and I'll discuss a little bit about this. So while we collect the data for our 136 goals and all the statistics about our children that are born hearing, it's also a collaborative effort. We partner with the Bureau of Vital Statistics as well to gain some of the information, and we also partner with our labs and the hospitals to make sure we're getting all the information necessary to track these children and infants appropriately. So the Centers for Disease Control and Prevention's Hearing Screening and Follow-Up Survey, this is an annual survey that all of the states report their hearing screening and diagnostic information to. So we also submit our information through an annual survey to the CDC, and then it's made publicly available after that data is compiled from all of the states and analyzed by the CDC. So we use the CDC's definitions for screening, diagnosis, and intervention data, which I've already discussed those with you all, which is essentially whether or not they had an actual clinical exam for hearing diagnosis, and then whether or not they were referred and enrolled in early intervention. We also use spatial analysis. So we use ArcGIS Pro. It was conducted to determine the distribution of our infant population in relation to the local Early Steps offices. And we use 2015 to 2016 data. That's 2 years worth of data because that's the data that was publicly available at that time. And of course, no matter the program you're in, you always want to make sure that the data that you're studying and that you're publishing, you want to make sure that if there are regulations on that data, that you adhere to those regulations. Babies are a vulnerable population by research standards in any field, and so it's very important that we use the utmost care when we're using their data, distributing their data, or publishing it. So I wanted to make sure that we only use data that was already publicly available. So some of the software used, again, use ArcGIS Pro for the spatial analysis. Microsoft Excel was used, which most people have access to Microsoft Excel. This is a really great tool that you can use to conduct statistics, different analyses. It can get pretty advanced if you'd like it to. I have a background in SAS. However, I know that a lot of the colleagues I've worked with, or just in my program area specifically, we talk better with each other in Excel, and it is very important to me to be able to communicate with the people I work with and those that need to understand the data in ways that are the easiest, especially as a public health professional. So another publicly available data set, Florida Health Charts. It's a data query tool. You can find it on the website, the Department of Health website. You can literally Google Florida Health Charts and it'll come up. There are tons of different tools on there. For this one, I used the birth data by county query. So essentially, I went to birth counts and I put it on the option for births by county, and then it gave me exact numbers for each county and how many children were born in each county per year included in this study. So results, fun stuff, a whole lot of numbers. So I will try not to bore you with numbers, but I will try to touch on like the key points because it's important for you to have some of these statistics when you're doing your own practice improvement or looking at your own numbers, because data quality is a very important piece of that process. So this is our mini chart on our program statistics and our 1 through 6 goal data points, which I'll get into the 1 through 6 goals in more detail in the following slides. But I just wanted you to see here. So Florida is actually the 3rd largest birthing state in the United States. And so with that being said, we birth a little over 220,000 babies every year. Of that population, in 2015, we screened 96.8% of those children. So 96.8% of those children had a hearing screening. And then in 2016, we had a screen rate of 97%. And so again, I'll get into these 1 through 6 numbers in more detail in the following slides, but I do want to highlight here an area where we found during the study and even during the time of reporting the data to the CDC for improvement. So if you look on the chart, you'll see a box that is highlighted in yellow with an asterisk in it. Total diagnosed by 3 months for the year of 2015. So in 2015, we found that our information system or our data system was not actually able to calculate the number of infants diagnosed with or without hearing loss before 3 months of age. And that's the children that had a diagnostic evaluation and whether that diagnostic evaluation happened before or was permanent or not permanent hearing loss by 3 months of age. So by 2016, you see, we were now able to calculate that number. So that was a big thing for us. We communicated and collaborated with our data vendor to make sure that by the following year and the years to come, we will be able to ensure data quality and provide that data point. So we're going to get into some national comparisons. So what our rationale here was that, yes, we know our numbers. We're looking at our numbers, but what do the numbers mean? If we're only looking at Florida's numbers, it could be a little one-sided. So it's important to look at what your program statistics are compared to the national statistics. And not every program has that availability, but I know that there are a few programs that you're able to look for national literature or research and data points to compare your statistics to kind of get an idea of how you're doing on average compared to the national average. So these are our 1 through 6 goals compared to the national average for the year 2015. So for the goal of having the children screened by 1 month of age, we had a 96.2% rate here compared to the national average of 95.5. So very close, but just above. So we were doing really good in that category. Again, for diagnosed by 3 months, we were not able to ascertain this data point in 2015 because of our data system and update in the software. So enrolled into early intervention. So we had 65.3% compared to a national average of 66.5%. So we were slightly below the national average. And then we have enrolled in early intervention by 6 months. Now, for the enrolled in early intervention piece, this is specific to children that had actually been diagnosed with a hearing loss or impairment. And so you'll see where we have 59.5% compared to the national average of 65.3%. It's important to highlight here that our early intervention program is again housed within early steps. Now, that is our Part C early intervention for the state of Florida, and so that's who we refer to. And since it's another program area within the Department of Health, we're able to collaborate with them to get these data points. Missing pieces of this data include those children that are enrolled in early intervention and may even be enrolled in early intervention by 6 months of age. However, it's not reported to our program. And so we're working on making sure that we catch those children that are actually receiving services, or also the ones that aren't, because we want to get them to the resources available to them. And so I'll get into it a little bit more in detail later in the slides closer to the end of the presentation when we get into the discussion. But this number that's missing here could include children that were enrolled into early intervention through Medicaid or a private provider. Those statistics aren't reported to us, therefore we weren't able to report them to the CDC. So here are those same numbers for 2016. So we were right with the national average there, 94.8% per screen by 1 month, 86.7% compared to 75.9% diagnosed by 3 months, and that's compared to the national level. So now we're able to calculate this number, and we're doing very well in the category. We're actually doing better than average for the national number. And so we were really glad and happy to see that now that we have this capability, we can really see what impact we're making in this category. And again, like I mentioned earlier, every portion of the process or every step in the process is an area for improvement and can be an area for intervention depending on how you look at it in your specific program. So for enrolled in early intervention, we have 65.3% compared to the national average of 67.2%. Again, accounting for those children that are not included in this number that may have actually obtained resources or services from other resources. Then we have enrolled in early intervention by 6 months, so 59.5% compared to 67.3% in 2016. So the Centers for Disease Control, in that HSFS survey, they also collect loss to follow-up or loss to documentation. And essentially, there are specific definitions for that, but for our field, that means that we're not sure. I'll get specific. Screening, loss to follow-up, or documentation. Remember, we had that very high percentage in 2015. I believe it was 96.8% of those children were actually screened. So what happened to the other portion of those children that weren't screened? So we saw that 1.5% of those children that were not screened were actually lost. We found that they were lost to follow-up or documentation. So we don't have a documented hearing screening, or we were not able to get in contact with either the parents or caregivers. And by the time this information and data was reported, they had not had a hearing screening. And so for diagnostic, loss of follow-up, and documentation, this population is specifically those children that did not pass a hearing screening. So they had a hearing screening, they didn't pass it, they needed follow-up testing, so a diagnostic evaluation. But at the time that this survey data was submitted, they had not yet had a diagnostic evaluation. And so here we have 7.2% compared to a national average of 27.9%. So we were doing really good. We did really well in that category for 2015. So the children that needed a diagnostic, most of them obtained one and received their diagnosis. And so then we have early intervention, loss to follow-up, and documentation. And these numbers are in line with the national and statewide numbers as far as those enrolled. So this means that the referral was made for early intervention, but we were not able to ascertain whether or not they actually enrolled into services. And so for the different reasons, there are many different reasons this can happen. Again, this is a very collaborative process because there are different people as far as like early intervention program managers, doctors, audiologists, parents, and caregivers. there are different aspects to how we obtain this information and how we get the children to those services. So for 2016, we had a 1.2% loss to follow-up for screening, which is slightly higher than the national average. And then we have 7.2% for diagnostic loss to follow-up and documentation compared to a national average of 25.4%. And then early intervention loss to follow-up was at 23.3% compared to a national average of 19.6%. So here is where I got to have a little bit of extra fun. I did a spatial distribution of our population. So this is where that Florida Health Charts query came into play for this specific study. You can use it for multiple things, but this is what I happen to use it for. So earlier you saw the chart with all the numbers. That's where that total birth population, that Florida Health Charts was able to give me the total population born in the state of Florida for those years, because that data is reported by the Bureau of Vital Statistics. And so that's how I got the population number. I was able to convert that into a file that was that I could use in ArcGIS Pro as a data layer. And so on the left side, you'll see that I have mapped the local early steps offices. And so you see the Western Panhandle, they are color-coded to represent what counties that local early steps office services. So you see the Western Panhandle, they're up there in green. You see the Big Bend, Tallahassee area, Big Bend, Panama City. And so Big Bend, Tallahassee, and Big Bend, Panama City, Big Bend is considered as one local early steps office because it's the same vendor. But they have two locations because of the distribution of their population. So they have one in Panama City and one in Tallahassee. And so as you look through that, those are the different locations. In Miami-Dade County, there are also two locations, one labeled as North Dade and one labeled as the southernmost coast. When you look to the right, to that graph, now you see all of these little dots represent the population. So these are babies born in the state of Florida. And so you'll see we have a high population in central and southern Florida, and then northeastern in the Jacksonville, Duval County area. You'll see, the dots in between counties, and so that might represent more rural areas where children were born. And then I have the data chart on the side that one dot equals 50 babies. So again, this is representative of the 224,000 babies that were born in 2015 in the state of Florida and what that population looks like. The awesome thing about GIS is when you want to do mapping things like this, they are not going to, the software itself accounts for the need to protect identities and locations. And so when this was entered, even when the data was pulled from Florida Health Charts, none of this has specific addresses attached to it, which was very, very important since I'm dealing with data regarding babies. 2016, so of course, same county areas for each LES office, and this is what the population looked like in 2016. And so again, we have very high populated areas in Central and South Florida, and then Northeast Florida and the Duval area. And then we have the in-betweens, which is still a lot of babies being born, but we see there are a good amount of them in rural areas as well. And I would encourage you to, when you're looking at a spatial map like this, to think about the location of where these dots are represented as far as the county compared to where the local early steps office is located. And so for the local early steps office, those are specific addresses. So those are pinpointed to the counties in which they are located. So you see Big Bend, Tallahassee, that office is actually in Tallahassee. So those points are specific, but the points for population are not. They're just clustered into each county, each of their respective counties. So discussion, let's talk about what happened, what we found in our data. So with loss to follow-up, loss to documentation, so we saw in the charts that were provided earlier that we had a few issues when it came to the early intervention point. We also saw, screening and diagnostic loss to follow-up. So this is a reminder that our process is a very collaborative process. Engagement and involvement of our key stakeholders, such as birth hospitals, audiologists, audiology centers, any center that tests for hearing loss or impairment, any center or entity that does hearing screenings, also the parents, the providers, the caregivers, other programs, so the Bureau of Vital Statistics, the Early Steps program, which is also in the Division of Children's Medical Services. And then we also have the private sector. So for that number of children that may have been receiving early intervention and may have been enrolled by 6 months, but we're not able to ascertain that because we don't collect that data just yet. So we saw that that was a huge area for us to be able to look into, like see how we could improve this area, what was going to be necessary for us to improve the outcomes for these children, or even just to improve reportability. So early intervention, again, the loss to follow-up, loss to determination, we talked about that a little bit. So we have a non-integrated data system. So this is something that happens when you're collaborating with different program areas. Thankfully, the Early Steps program is within the Department of Health, so it's a little easier for us to collaborate. I know that when you all are conducting research and studies, it may not be so easy. So we don't have an integrated data system. Our data information system is completely separate and different from that of the Early Steps office. We do work with them to be able to pull the information we need to report to the CDC on an annual basis. And I actually currently participate in their Early Steps data work group along with several other key stakeholders throughout the state to ensure data quality and, provide feedback on the needs of the system and how we are to share information and collaborate in the future. And it's all in efforts to ensure positive outcomes for the children in the state of Florida. So EHDI our EHDI information system, data system fixes. Again, in 2015, we saw that our system wasn't capable of calculating an important number to report to the CDC. And so we couldn't document whether or not the children were being diagnosed by 3 months of age, which is really important. And so we were able to get with our data vendor, talk about what we needed, show them exactly how it needs to be calculated, and now that's been implemented within our system. And so we've had from this research and from everyday practice, we've been able to ascertain what areas that we needed to improve as far as our data system capabilities and to improve our data quality. And data quality is very, very important because if we're going to report this to the CDC and they're going to distribute it nationally, we want to make sure that they have accurate numbers. And then accurate numbers also lead to more positive outcomes because if we don't have proper data quality, how can we ensure positive outcomes for our children? So then new capability for audiologists to report electronically. So our process that we talked about, the process of diagnostic evaluations being reported to us. The process for years has been that those audiologists fax in results. And so we wanted to make sure that it was easier for audiologists to report that data. And so now we have an electronic reporting system called eReport, and we are training audiologists. We're in the process of rollout, so we're training audiologists to be able to use that system. And so now they can just go online, log in with their information, and provide very detailed information on the evaluation that was conducted, and it's submitted in real time. And then Florida's geography. So we saw when conducting the spatial analysis where our population of children were located in comparison to the local Early Steps office. We did see that in the future it would be beneficial for us to look at more specifically those children diagnosed with hearing loss or impairment in comparison to the location of those offices, and then also ascertain other resources in those areas because we do know that we have some large rural populations as well, in addition to the large populations of children that are surrounding the South Florida area, Central Florida area, and Northeastern Florida area in those larger cities. So what are our next steps? So again, we have electronic reporting for diagnostic evaluations. Everyone has not yet been trained about that. but we are rolling it out. So if you're an audiologist and you're listening, definitely get in contact with us because we have a new system that you can report easier to. We have a needs assessment from stakeholders to highlight gaps within the state. So we have partnered with the Florida School for the Deaf and Blind, again, stakeholder engagement. So we've partnered with the Florida School for the Deaf and Blind, and they are for them to provide parent support for those children and parents that have children that have been diagnosed with a hearing loss or impairment. And essentially they are able to roll out this needs assessment to find out what do the parents need, what do the children need, what are some areas in which they're not getting the resources that they actually need. So hearing loss follow-up kind of ties into that a little bit. We now are developing a specific process for additional follow-up for those children that are diagnosed with hearing loss and impairment. So where we saw in that loss of follow-up for early intervention, we said, let's see how we can improve on our end to make sure that we're following up with those children. So even if they're not obtaining services from the early steps, their local early steps offices, we want to get in contact with them just to make sure that they are receiving services. So we have a parent support consultant within our program area that is reaching out to these children's parents or caregivers, seeing if they are aware of, that diagnosis. Are they aware of the resources available to them? If they aren't, tying them and connecting them to resources in their area and making sure they're aware of everything available to them and getting them connected. So these next few points are all about stakeholder engagement. So we wanted to make sure that the stakeholders that are involved, and I say stakeholders, but it just means people that are very important to the process, anyone that's involved in the process of making sure that a child is screened, diagnosed, and enrolled into early intervention. So developing educational materials for our program to provide to audiologists. So audiologists, we can't assume that every audiologist knows about our program. So most of our educational materials in the past have been catered towards parents. So we've developed new educational materials, and we're in the process of developing new educational materials to provide to audiologists so they are more aware of what it means for hearing screening to be conducted, what the state statute is, what does that process look like, and why is it important for children at that age. So we have exhibited at an audiology conference, and we'll continue to exhibit at audiology and pediatric conferences within the state. And that's, again, going, having a booth, talking to the audiologists and the people there, letting them know that we exist, what our program means, what we're doing, how they can help the children in the state of Florida. Partnering with universities that offer doctoral programs for audiology. So there's previous research that has shown that, even in regular medical school, that it's beneficial to introduce these types of topics to students while they're still in school. So for doctoral programs of audiologists, if we go into those programs and we partner with those programs to give them information on our program, when they become a new audiologist and they are out in the field, they know about EHDI. They know that we need to see the results that they are conducting. We need all the evaluations. We need to know the information so we make sure that the children are being well taken care of and have the resources that they need. And then partnering with state licensing boards as well. So that just that expands the network even more so we can distribute the mission and goals of EHDI, let them know what's going on, make sure that they're aware. So using all avenues of contacting the people involved in the process to make sure they're knowledgeable and know how they can help achieve the EHDI goals. So limitations of the research. Most studies have limitations. So as we're talking about evidence-based practice and using the data and resources available to you, I do not want you all to get discouraged when your research is not perfect. There are, in previous research, they usually denote their limitations. For our specific study, again, our information system wasn't able to calculate the 3-month goals due to a software update. As far as the spatial analysis is concerned, the local early steps office, they separate Miami-Dade County into 2 separate service areas for regional service distribution. So when you get into the deepness of what it is, ArcGIS Pro, you need special software and capability to be able to separate the population of Miami-Dade County into those two service areas. So I used the data population from Florida Health Charts. Now, that query does not separate Miami-Dade County's population into those two service areas. So that proved to be a limitation of the study. We weren't able to distribute the population within Miami-Dade County according to how they're distributed by region for the local early steps offices. Now, these statistics are specific to Florida. The results are not generalizable to the national population. However, the methods can be used to duplicate this type of study for other states and territories. And so a major thing to highlight here, the major purpose of this webinar and me presenting the information to you in this way, you can find ways of using your resources such as Excel, SAS, whatever statistical analysis software you use, whatever resources are available to you. There are ways to look at previous research to figure out how to conduct your own research and how to move forward with analysis, critical analysis of the data available to you for program and outcome improvement for your population. So, conclusions. We realize and recognize the importance of stakeholder involvement in our EHDI process, the importance of data quality for improvement of program outcomes, knowing that as we improved our data, we were able to see a better picture of what was actually happening in the population for the state of Florida, what was actually happening in our EHDI program, what were the real areas for us to be able to improve on or provide further intervention for. Use of creative methodologies and practice-based research. And so again, this is, using the resources available to you, not feeling or thinking that you have to just stick to one statistical analysis software, being able to be very collaborative in your research, study design, or even in your practice improvement study design. Just making sure that you don't feel that you can't conduct research or you can't figure out how to improve your outcomes or program practices just because you're not sure of how to use like SAS or SPSS or STATA or something like that. Further research is necessary to examine statistically significant factors that impact EHDI outcomes and geographical trends in the EHDI outcome data. And this is a major point for me because, like it was said earlier, I have a background in epidemiology and biostatistics. And so when we're conducting statistics in SAS or SPSS or STATA, it's important for us to find what extraneous factors. So if it's demographics, is it actually geography? Is it socioeconomic status? What type of factors are involved as far as our population is concerned, and what factors are affecting the outcomes of the children? What outcomes are affecting whether or not they're getting to services, whether or not they're being enrolled into services, whether or not they're getting a hearing screening, and whether or not they're getting a diagnostic evaluation. There are so many factors that could impact that process. So it is important for us in the future to examine which of those factors are statistically significant. And that just means which one of those, the numbers are more than just percentages. That means this is a real area where we can intervene to improve our outcomes. So here are my references. Questions?
Great, thank you so much. This is a wonderful presentation. Does anyone on the line have questions?
Are they muted or they're typing in?
Just a reminder, all the people listening on the line are muted, so if you have any questions, please submit them to the question box on the GoToWebinar panel.
Is there anything in there?
Does anybody in the room have any questions?
I'm definitely cool with that.
Yeah. Just a reminder that this presentation has been submitted for continuing education credits, but it has not yet been approved. Still go ahead and complete the survey, which will pop up at the end of this presentation, or will be linked in the follow-up email. You don't have to complete it both times, just do it once. After all those names are collected, I will create certificates, but we do need to wait for either continuing education approval. If for whatever reason it's not approved, I will create certificates of attendance. when you complete the survey, it's important that you put your name. I can't create your certificate if you don't put your name. And last month, lots of people left their name off. So please do that. Just a reminder for anybody who joined late, this was an example of a research excellence initiative project that was done in the past, and we will once again be having that program available Class 6, and information will be going out about that in early January. Okay. So we still don't have any questions, so we're just going to go ahead and end early today. Wait, one thing, sorry, I forgot. Our next presentation will be on February 11th at 10 a.m. We will be featuring Dr. Christopher Kogel. He will be presenting on the Florida Cancer Plan, and to register for that, we will be sending out a link similar to the one you received today. And then we just got a question: will Early Steps pay for the screening for someone who failed it at birth?
That is a really great question. I don't know what the contact methods are, but if Etta could get your contact information, I can definitely find out for you and let you know.
Yeah, so the person that asked that question, I will send you my email, and if you email me, we'll send you that information. So thank you, everybody, for joining us, and have a great day.
Great. Thank you.